Good morning, everyone. Welcome for our monthly live session for peripheral interventions from Mount Sinai Hospital. Today is the November 16, 2016, and I'm Vishal Kapoor. Before we head you to the lab for PK and his team for another exciting case, just wanted to let you know to log on to our website, peripheраlinterventions.org, for seeing any previous archive cases in the archive section, in case you missed any of those live presentations from the previous months. For any questions, you can email us at info@peripheраlinterventions.org for a feedback, a question, or a concern. We just would love to know your thoughts and get any advice from you. And also, before we go ahead to the lab, our next live broadcast will be on December 21st, which will be a Wednesday. So let's take you to the lab. Morning, PK. How are we doing?
How are you, Vishal? I'd like to welcome all of you here. So we've got a very interesting case of a difficult patient who's had some issues because of his diabetes. So anyway, before we start, I want to welcome everybody to our cath lab. So we're fortunate enough to have Dr. Karthik Gujja here to join us in the lab like you did last time. We've got Ray, we've got Suraj, our interventional fellow. We've got our endovascular fellow, Dr. Farhan. We've got Elizabeth, our nurse, Damien Cabrera, our tech. And we've got the good folks from Philips Volcano to help us to really explain this newer device. It's not new, but it's definitely a newer device that's starting to gain a quick foothold in the world of atherectomy for the treatment of peripheral arterial disease. So we got a very interesting patient, which I think really is reflective of all our patients that we deal with in our practice. And I think I'm going to have Dr. Majid go ahead and discuss this particular case with a history and presentation.
Good morning, everybody. So we have a very interesting patient. This is a 79-year-old male with a history of diabetes, hypertension, and hyperlipidemia. The patient presented to an outside facility with a non-healing ulcer on the dorsum of his left foot. Rutherford grade 3, category 5, Fontaine stage 4. The patient was evaluated by vascular surgery at the outside facility and underwent a wound vac placement on the ulcer due to its non-healing nature. The patient actually followed up with us in the clinic, and due to concern that this was an ischemic ulcer, the patient was brought for a peripheral angiogram. Next slide, please. The patient's past medical history is significant for diabetes, hypertension, and hyperlipidemia. His medications include aspirin, statin. He's on multiple medications for his blood pressure, including hydrochlorothiazide, amlodipine, atenolol, and benazepril, and diabetes medications, including metformin and insulin. He doesn't have any allergies. He's a longtime smoker and quit 20 years ago. No family history of any problems, and otherwise review of systems is negative. Next slide, please. On examination, blood pressure is well controlled, heart rate is well controlled, cardiovascular exam is normal, respiratory, he's got clear lungs. On his extremities, he is noted to have an ulcer on the dorsal aspect of his left foot with a wound vac in place. He has diminished 1+ DP and PT pulses on the left foot and normal pulses on the right. Laboratory data reveals a hemoglobin of 12, platelet count of 315, and a creatinine of 1.2. Next slide. PK, you want to go over the angiogram, or you want me to?
Yeah, no, I think you should go over the angiogram.
Okay. So you can see this is the aorta is normal. The common and external iliac are fine without any significant disease. Next slide. This is a runoff. You can see that the mid SFA has some mild disease, and the distal SFA has some mild to moderate disease. The distal runoff here will clarify with some DSA shots next. Next slide, please. So here is the trifurcation. You can see the anterior tibial has just minimal disease in the proximal portion. The PT is subtotally occluded in the proximal portion, and the peroneal is also subtotally occluded in the proximal portion. Next slide. The mid segment shows that the AT has moderate disease, and again, severe disease in the PT and peroneal segments. Next slide. Here you can see that the distal segment of the AT has severe 90-95% disease. You can see reconstitution of the PT at the level of the ankle, and severe disease throughout the PT and peroneal. Next slide. Here's the dorsalis pedis. There's severe disease at the, you can see in the dorsalis pedis, and you can see a slight coming in of the PT in the foot, but nothing significant there. Next slide. So in summary, this is a 79-year-old male with diabetes, hypertension, hyperlipidemia, who presents with a left dorsal foot non-healing ischemic ulcer. Peripheral angiogram shows severe left infrapopliteal disease, including severe disease in the AT, PT, and peroneal arteries, and the patient is here for planned infrapopliteal intervention.
So, you know, as you can see, I mean, we have a very difficult patient who has, you know, multi-level disease in a very dominant anterior tibial artery that's running into the foot with the wound. So our options for treatment in patients like this are really starting to, you know, how can you say, really break down into two. There's very limited data below the knee. You know, there's endovascular versus surgical data. If you look at the basal trial, which showed both were equivalent. However, in long term, if the patient survived, there was some sort of survival benefit after 2 or 3 years. There's a lot of controversy over the basal, but however, that's the only data that we really have. The BEST trial is actually ongoing and enrolling. We'll definitely go ahead and add a lot of, you know, how can you say, clinical data to that, and we'll may start to guide our therapies. And then if you look at, you know, Basel 2 and Basel 3 in Europe, which are all ongoing at the same time, to go ahead and, you know, again, help us to use data-based decision making in helping these patients. 3 things I think that are unquestionable here. One is the patient needs to be metabolically controlled. That means his diabetes, his dyslipidemia, his blood pressure, maximize his medical therapy. I think everybody would agree with the question that needs to be done. So you need to work in coordination with the wound care clinic. Second thing, I think it's unquestioned that the patient needs to have some sort of wound care. So local wound care, take care of this wound vac with the wound care experts. Third, and unequivocally, the patient needs to be revascularized to maximize the blood flow. Now, some of the current limitations that we have is, first and foremost, are we actually, revascularizing the site that needs the blood? So one is we use angiosome-based therapy, to say that this is the angiosome that's supplying the wound, with the hope that that may be enough. 2 is there's a belief in doing global revascularization. There was a recent paper that was published that looked at opening up both the arteries may be more beneficial than opening up just one. And the third one is there's new software. Philips actually is coming out with some perfusion software. I forgot the name of it. Maybe they can whisper it in my ear. What is it? 2D perfusion, which I think is going to help us a lot in terms of being able to do angiographic guided assessment of our perfusion to the wound pre and post our intervention. Now, there's also, indocyanine green, which we can use. Methylene blue has been used. You can do TBIs pre and post. You can do, tissue pressures pre and post. These are all very non-specific, and I think we need to really have some real clear assessment, and I think we are getting that through either imaging with the transducers or with the camera itself, or with injecting contrast or specific types of contrast in. Second is we need to really figure out what's the adequacy, in terms of our intervention, Dr. Guja, Dr. Kapoor, because I think 2 of the things that we know is the use of IVUS, intravascular ultrasound, and first and foremost sizing the vessels and deciding. So I want to go over a little bit of a presentation here before we go, which is kind of a little different than what we've done in the past, and then we'll get to the case. So can you clue up the slides here, guys? And then I want to ask Dr. Guja and Dr. Kapoor to start commenting on this. So I think importantly we need to decide what is the role of adjuvant imaging in these particular vessels. Okay, next slide. So I mean, right now we have 2 important forms of intravascular imaging that we can use in the cardiac cath lab, or in the vascular suite or IR suite. Doesn't matter where you're doing these procedures. One is obviously intravascular ultrasound. Second is optical coherence tomography, or OCT. So OCT as such at this stage is still in its infancy in the endovascular space, although a lot of research is being done with it. But the data with intravascular ultrasound is actually quite mature. And we've participated in some of the studies that have really helped clarify the role of this particular mode of imaging in the peripheral arterial disease. So I think three things most people will accept very, very clearly. One is IVUS provides more detailed info than angio alone, and thus potentially can help develop an algorithm for treatment by assessing the luminal gain, assessing the how can you say, the burden of calcium, assessing possibly thrombus, which maybe the jury's out. Some say you can do it, some say you can't. But I think one thing we would agree that angio alone does not give the same level of detail about lesion morphology and geometry that IVUS does. Next, please. So how does data affect your treatment? Well, listen, we all know that a calcific lesion doesn't behave the same as an atherosclerotic lesion, doesn't behave the same as a thrombotic lesion. I think what's important to remember is study data suggests that determination of overall vessel diameter and interpretation of plaque morphology by angiography and IVUS are really discordant, that IVUS is really more sensitive and specific. That's also true with calcium, okay? I think IVUS is also being able to pick up the grade of calcium, the arc of calcium, and whether the calcium is really adventitial or intimal, where it's present in the lesion. And third is the importance also, that can also help guide in the terms of what are you going to do? Are you going to do a balloon angioplasty and a supera stent? Are you going to do a directional atherectomy and a DCB? Are you planning on doing a shockwave therapy maybe in the future? Or are you planning on doing a non-directional atherectomy like the Phoenix device to see what it is that you want? And I think the important point is, in interventionalists, I think we're learning that we cannot necessarily just trust our eyes. We need to do adjuvant therapy. And I know I hate to put the coronary analog in there because I usually throw my coronary hat in the garbage when I do peripherals. But the truth is there is a lot of overlap in terms of understanding the lesion and how you're going to go ahead and treat it. Next slide, please. So we actually did this one study, which we call the Utopia study. Wasn't published as a Utopia study, but it was presented in the, I believe it was TCT or ACC, I can't remember when, but many years ago. But it was recently published in Jevid, where our team, Dr. Guja, Kapoor, myself, actually looked at the extent of injury on the adventitia as it relates to restenosis as detected by IVUS. So basically, as you would imagine, injuring the adventitia or deep cuts into the vessel wall leads to higher rates of restenosis. So that's clearly proven and published. Next, please. So the other thing we did right after that was, this is the results, as you can see, showing a tremendous difference in restenosis if you do injure the adventitia. And this may also be true in the DCB era. So now if you do decide to do whatever type of atherectomy and you injure it in some way, now you know that maybe drug-coated therapy, once you've identified it by intravascular ultrasound that you've created an injury, giving the drug to that spot may retard the restenosis, which we don't know needs to be proven. What we did prove in another study here, in a letter to the editor that was published maybe a month ago, myself, Dr. Guja, and Dr. Kapoor again, we actually looked at the utility of IVUS in identifying adventitial injury and found that IVUS was very, very useful as long as you are able to do it pre and post and actually identify the area where you injured the vessel. So then now using a drug-coated therapy or a supera in that spot may help retard the restenosis. Next, please. So now I guess that comes to the question, can IVUS assist your treatment strategy and outcomes? Next. So again, I think one is two things you can do. We know the reason to do atherectomy, whether it's Phoenix atherectomy or directional atherectomy or rotational atherectomy, is to first, once you do it, you want to assess, have you done an adequate amount of atherectomy? Meaning, have you affected the calcium enough? Have you affected the plaque burden enough? And have you or have you not injured the vessel? So one, so I think that's important. Number two, IVUS can also help you size your balloons. I think one thing that we've seen very, very clearly, even in the peripheral literature, if you do IVUS-guided stenting, if you do IVUS-guided balloon angioplasty, you definitely are better in terms of sizing one-to-one versus not, and that would make intuitive sense. And again, as we stated earlier, IVUS clearly can help you prevent injury or at least identify the areas where you need to do atherectomy. So again, it gives you a little bit more visualization. Next, please. So again, I mean, I'm going to skip this slide next. I think I've hammered that home. So I want to go over this Phoenix atherectomy system, which Dr. Guja is going to demonstrate. He's probably got the most experience out of all of us here. So the Phoenix atherectomy system is basically a hybrid solution. Next. And I'm going to let you play the video.
The Phoenix is a simple-to-use system that is powered only by a motor within the handle. No capital equipment or additional procedural accessories are required. Phoenix operates without the need to control cutting RPM, and can continuously debulk for up to 20 minutes. The catheter's over-the-wire design provides support to aid pushability and deliverability and has been proven effective in navigating tortuous anatomy. Because the cutting element is located on the distal end of the catheter, the Phoenix can immediately begin treating highly stenosed lesions without having to first pass a nose cone. The center mass cutter design clears tissue in a way that may help reduce potential trauma to the vessel. As the cutting element rotates, disease is debulked at a controlled diameter and is continuously captured and cleared from the body. This allows for blood flow to be quickly restored to the distal vessels.
The important thing is that, if I was to give you some acronyms to remember this by, it basically continuously captures and clears the plaque. So I think that really helps you to really focus on the therapy, knowing that the device is doing it continuously without having to clean the catheter, watch where you're cutting, where you're going. As long as the wire is interluminal through and through, I think you're fine. So if you see some of they call it next generation. I don't know if it's next generation. It's atherectomy, and I think it's a different form of atherectomy. I think if you look at the advantages and disadvantages, I think every atherectomy device has to be taken in its own merits for sure. But I think clearly Phoenix does some things very, very differently. One, it's front cutting for direct lesion access. Two, it continuously removes plaque, which is again a burdensome issue. If you have a long lesion in a directional atherectomy cutter, you do have to clean it, often. The larger devices are steerable and have directional capability, so you can do that. And it's a single insertion, like you said, 20 minutes. So what is it, 20 minutes or 25 minutes? 20 minutes. 20 minutes that you can leave it in. And again, the need for capital equipment is obviously not even there. So which again helps in smaller labs, OBLs, et cetera, et cetera. So I think the other ones, as you see, also have their advantages and also have their places. So I think that, importantly, using the intravascular ultrasound to guide you will help you to choose the right directional atherectomy catheter or the right atherectomy catheter. Some of these, such as the orbital rotational, are not directional. Laser is directional. Phoenix is directional, as is obviously Silverhawk. So if you have eccentric plaque, that may be one to go. Size of the vessel may be an issue. So, you can use the IVUS to say which is the largest size vessel that you can do this in and then decide. So I think there's a lot of advantages to doing intravascular ultrasound, but clearly having a newer generational atherectomy catheter helps. Next, please. So it's safe. I think anytime you have a new device in the lab, the question is it safe? Again, if you look at some of the data that's available in the EASE trial, which we're going to go over very briefly, it has a 1.9% perforation and a 0.9% dissection and less than 1% distal embolization without the use of distal protection. So it really shows that this Archimedes screw really helps you to be able to remove the plaque without actually showering it distally. Next, please. So again, I'm going to look at the EASE trial. And I think the EASE trial, I don't believe it's published, or maybe it's published, I'm not sure. I know it's been presented, so that's where we got these slides from. So the EASE trial basically is the data that's available at this time. So it looked at the ability of the Phoenix to effectively treat a broad range of tissue types, from soft plaque to calcium for lesions above and below the knee. And in this case, you'll see we're going to use 2 Phoenix catheters, but I'll explain to you why. So there's 3 catheters diameters which are available to be treating in the peripheral, from the smallest vessel to mid-sized vessel to the largest size vessel. So you have the 1.8 and the 2.2 millimeter, which are non-deflecting, which means you cannot steer them towards eccentric plaque, but they're ideally suitable for smaller vessels. Say below the popliteal artery, it's probably reasonable to say that. But they're very, very trackable, so they're easily tracked through highly stenotic lesions. The 2.4 is the deflective vessel. I know Dr. Guja's got, I'm going to have him comment on that in a second. He's done that in the SFA, but clearly it's suited for larger vessels or eccentric lesions, and he'll comment on that. You can see the sizes of this. Next, please. So if you look at the ease of use, again, we went over this. It's a battery-powered handle that Farhan and Ray will show you how it's done. It's low profile, and it's easy to track. Next, please. So here's the data. Next. So you can see it's a single-arm study, multi-center, FDA-approved IDE study in the U.S. and Germany. Lower limb atherectomy with or without adjunctive therapy, with follow-up for 30 days and 6 months. And then independent adjudication of adverse events, which is important. Next. So 105 total patients, 123 lesions enrolled. The endpoints were acute debulking with less than 50% residual stenosis was considered a technical success. 30-day adverse events were looked at, and it was done by our friends Dr. Davies and Dr. McKinsey. So all three sizes of Phoenix catheters were included in the trial. Next, please. So you can see here your Rutherford category, your RVD average was 3.52, lesion length was 34 millimeters, and average plus 929, and 33% of the patients was CLI, so like this particular patient. Next, please. Excuse me. So above the knee, they had SFA and popliteal lesions, as you can see, and BTK was also performed with equal distribution almost of all the vessels except the perineal. 72% of the lesions were below the knee, and 42% had a single or less than single vessel runoff. Next, please. So pre-treatment was really unnecessary with this lesion. Distal protection was not used with this device, and there was almost a 0% rate of bailout stenting. And if you look at the runtime, it was 5.9 minutes was the average using this. So I think it's a very effective device and reduces your time of treatment. Next, please. So here's one of the first cases enrolled. Difficult case, much more difficult than what we're showing you. Looking at the occluded AT with the Phoenix alone, with a beautiful result without any real flow-limiting dissections on this particular device. Next, please. So if you look at the effectiveness endpoint, 95.1% successful, safety, very safe, only 6 events out of 105, and the events were clinically driven TLR was 1, perforation, they did have 1, probably a CTO, grade C dissection occurred in 1, again, very, very small numbers. Distal emboli requiring intervention was almost 0, and an unplanned toe intervention in amputation occurred in 2.9%. We don't know why, obviously this has not been published yet, but clearly it shows that this is a very safe device to use. Next, please. So if you looked at the important clinical endpoints, over time there was a greater than 1 change in Rutherford class at 30 days and 6 months. And if you look at the Kaplan-Meier estimates at 6 months, showed freedom from TLR and TVR were very acceptable in this very good in this very, very complex lesion subset that were treated. Next, please. So in summary, I think I can say here, based on the data from the Phoenix system, this is a safe and effective atherectomy for the peripheral vasculature. I think this trial basically met the predefined performance endpoints that were defined and really was shown to be effective in these complex lesion subset. So I guess the philosophy would be cut, capture, clear really makes it easy or ideally suited for small vessels or highly stenosed lesions. So these lesions are really not necessarily good for distal embolization and don't tolerate distal embolization well and really don't have landing zones to place filters, and the filters are not really ideally suited for these particular vessels. So therefore I think that here, if you look at it, this is a device that may really help you in these complex lesions. Final endpoint, I think imaging is incredibly important, and I think using intravascular ultrasound, as you're going to see what we're going to do here, is going to help. So again, I thank you for your attention. I'm just going to go ahead and kick it off to Karthik. And any comments on this device, Karthik? I know you've used it in your practice quite a bit. I mean,
I personally like the device. As PK said, it's cut, capture, and clear. So it's a great device, especially the 7 French device, which they have deflectable for SFA is great. If you have eccentric calcified vessels, it's good. Below knee, I think 1.8 and 2. 1.8 is mainly for the below knee vessels. 2.2 is mainly for the popliteal and I would say proximal below knee vessels. And SFA, I think it's 2.4. I think we'll show the device when PK is ready.
So I always tease the Volcano people that the atherectomy device is actually their IVUS device. But the truth is, you can see that here, we're very much distal in the foot with a very trackable Volcano IVUS device. So as what we're going to do here is we're going to look at the size of the vessel and really look at the plaque. So go live on the IVUS, please. Show us the IVUS. So we're going to go ahead and start pulling back. You can see it's pretty much around the device. So we're going to pull back. Dr. Guja is going to slowly pull this back. And you can see that it's currently very, very stenotic. You can see that's the stenotic area we were in. And as we come back here, it's basically a 2 millimeter vessel, right? And it may be a 3 in this area, but really 2. And then you can see as you pull back further into the anterior tibial, the vessel is going to plump up. And you can see, right there's another lesion, but keep going. we're going to need to go a little slower. Find the lesions, the really tight areas. Right there, you have some eccentric. Right there, that's the lesion right there. It's around. I think we're going to need a bigger device in that spot. But keep coming back again. A lot of eccentric calcium as well as concentric calcium. A lot of calcified plaque, which you can really see very well with this device. There's a tighter lesion there. And you can see there's a lot of areas where the vessel is larger and smaller. So I think in the foot here, we're going to go with the 018 device. I think it sounds reasonable, gentlemen, right?
1.8,
I'm sorry? 1.8, excuse me, 1.8 device. And then we're going to upgrade for a larger device up top, right? The 2.2 device, right? So I think that's reasonable.
So PK, we have one of our questions here. They just want to know, is there a calibration chart which says a 1.8 can be used from this millimeter to this millimeter vessel, and then a 2.2 and a 2.4? Do they have a specific recommendations for the vessel size?
Yeah, the 1.8 device needs at least a 2.2 vessel, and the 2.2 device needs at least a 2.5 vessel.
Okay.
So I think that's a good shot here. We'll take this out, and we'll go ahead with the atherectomy device. I'm going to allow Dr. Guja to guide us here because I know he's done quite a bit. But Ray, are you mic'd? No. Ray's not mic'd. So maybe Dr. Guja can go over this, and maybe you can put it together in front and redo the whole thing for everybody to see. Don't lose
it's already clipped in.
Well, take it out, and we'll do it again.
So basically, it comes in as this. Normally, what we do is we have to flush in. When you flush in, you flush the. This is the port where the plaque comes out from. You put your hand in the port and then flush the whole device clean. This is your cutter. As PK said, it's a head-on cutter. And then you take the device and just pretty simple. Basically, just clip it in, go in, and just lock it in. Once you lock it in, this is the wire holder. Just like the rotor device we have, they have a wire holder where it prevents the wire from spinning in, distally. You actually take this.
Karthik, can you mag up on the cutter head for us? Keep it on your palm. Yeah, just against your, yes, perfect.
So if you see it.
Yep. So guys, there's two cutters, right? There's a front cutter and a side cutter.
Okay.
So what is this? Two sets of cutters. Sorry about that.
Two sets of cutters.
Two sets of cutters.
So this is your front set of cutter. This is your front cutter, which is like a screw in. And the side cutter comes in right on the side here, which basically keeps on drilling it, and it completely drains it into the main pole.
So basically, the front cutter cuts front, the side cutter pulls it into the device, the Archimedes screws constantly clears the plaque out, so you're not going to be embolizing. So it's a very effective little device.
So let's do it on the water, and you see this is the port where it actually drains it out from. This can be connected to a bag if you're doing an instant or something. This can be connected to a bag to look for thrombus. But when you actually do this, you can actually see fluid coming out of the port right there. See that?
Yes.
Right from here. You see the fluid coming out. That's the way plaque comes out. So basically, if you're doing it, it keeps on cutting and it keeps on draining off. So it's like you can say it's like a suction device, like a thrombectomy device as well as the atherectomy. Like we have other devices in the market, but this for the below knee vessels, this works very well, especially for tibials, and it gives a good clearance system. So
essentially, it's a passive aspiration rather than an active aspiration.
It's not like an active aspiration device. It's a passive aspiration device. It goes basically based on the
Archimedes
the gravity pole. Right. It basically keeps on slowly releasing it. The amount of embolization rates based on the theoretical part and on the trial is much less. It's less than 1%. So if you use this on a long segment device, if you're going for 20 minutes, you really don't have to use any filter. So
we're going to now load this to the front, and okay, the important comment on the wire, and this is where I may disagree with the company a little bit. You know, obviously they need a very supportive wire, and currently they're saying the Viper wire is the best, which I totally agree. It's an incredibly supportive wire. The problem with the Viper wire is when you put it into these little small branches, like where this wire is in the toe, it may be traumatic. So I've asked them, well, you know, their blessings to go ahead and use a different wire. We picked the nitrix wire. I think the important part of the nitrix wire is that what's needed is that you cannot have any polymer on these wires. Guys, am I right about that?
That's right.
So if you have any polymer on these wires, what happens with the polymer is that it can be sheared off by the device itself. You don't have it yet? Okay. So now you can see here, we're loading it here. I'm going to go in a second. So we're loading it, Vishal. Now we're going to go in, Generally speaking, if you are using a Viper wire, I would want you to keep the tip of the wire in the field at all times. Don't move it, please. Tip of the field in all times. I think that's very important because as this device, even though it's not bulky, goes up and over, the wire could move and cause a perforation. So that's an issue. I think the Nitrix wire is a little bit better, but I think obviously they're going to work on better wires to help people like me who may be a little more paranoid than the average operator. The other thing also is that I think a long sheath is very helpful. So we put a 65 centimeter sheath down into the SFA. We avoided the disease part of the SFA, which again is going to help in terms of the pushability of this device and allow this device to do the work without having to fight against itself. So I think those are like key little technical points here. So we're going to try to go forward, you know.
Do you recommend prepping the vessel up with nitro and verapamil like we mostly do in below the knee?
Actually, we did, Vishal. That's a great idea. Now, Karthik's going to watch that, and he's going to hold that device. Allow me. I'm just going to go really slow. But what we did here, Vishal, is we went ahead and we actually prepped the vessel with tons of nipride. First and foremost, to make sure that there's no spasm.
Right.
Because again, as you know, these distal vessels can spasm. But our last diagnostic angiogram showed that there was no spasm. So what I'm going to do is take it all the way down. Now you can imagine I'm all the way distal here, almost in the phalangeal artery, and you know that's kind of the way we're going to really show how this works. So obviously the length, we're up and over. The length is going to help us as well, and hopefully we reach. You know, sometimes you get surprised, but this is a very long. Why is it catching it? It's a very long
probably
device.
lesions, right? All the plaque, no?
Yeah. There.
Stop.
Okay, we can get there. We can go a little closer.
One second. Pick it one. Yeah. So Vishal, what you want to do is, when the wire comes in, if you guys can focus on this, basically clip in like we do the rota clipping. Basically loosen the track, and we plug it into this, so that the wire doesn't
Advance.
spin and advance at the same time.
All right, can we zoom? You're hiding right behind the camera. That's
Sorry.
yeah.
Okay.
I think everybody
that's
needs
better.
to come to Sinai here. So you can see right here what Dr. Guj is doing is just locking it in.
So maybe
This is very similar to the
put it in like
pathway
a clip.
medical
This is
loop.
exactly
It's
the
very
same
similar
way.
to all those loops.
So you
Now, how
basically-
big should the loop be? About the size of your fist.
So normally this is how the loop should be. It depends. So if you put your hand in there, you can just say that's how big your loop should be,
That's a
and you
little
just
big.
lock it in.
It depends how big you are. Guys like Farhan will have a bigger fist. So we will move forward a little bit here. I want to come forward because that's not the lesion. I think it's important here to really cut the lesion and nothing. No te muevas, señor, por favor. No muevas. Let me grab it here. I got it now. Look up. Look up. Look at the device. All right, there you are. We're going to start here. Okay, so we're just going to make one quick pass on. Really 1 millimeter a second. Really allow it to go.
Just one time.
Off. Off. So we went right across that lesion. I'm just going to make one pass here. Let Dr. Gujo walk it out. Okay.
Watch
A lot of spasm there.
Yeah.
Give me a balloon, guys, just in case here.
Can we use the same
2-0.
aspiration port where it sucks out to inject any medications or anything that needs
Can
to
we
be done?
inject medication through this, guys?
You cannot. No, you cannot.
Okay. So it's not a free port, it's just an aspiration.
It's
Stuck, stuck?
Spasm.
Oh, it's just spasm, right?
Yeah, I got it.
So a lot of times when Farhan says stuck, you know, we don't listen. We just pull. So you could see
A lot of spasm in the vessel
a
itself.
lot of spasm in the vessel. Which is fine, we did treat. It's a smaller vessel. Just don't want to lose wire position here. And that may be because we didn't treat proximally either, but I know we have a good lumen here, it's not an issue.
A lot of spasm. A lot of spasm.
And reverse to coming up.
So what about in lesions where we cross subintimally? Is it still recommended when we can use this, or is totally not indicated?
Subintimal crossing is I don't think that it's recommended at this stage. I think, you know, we're obviously studying most atherectomy device in the subintimal space are not really recommended. So this is, you know, listen, man, this is challenging stuff. So now we're going to turn it back on here, right?
And then pull it back, Yeah.
Yep. So this is another advantage of allowing it to spin on the wire and walk it back.
That's why it's important that you have to use a wire which is not hydrophilic. I would not spin with this device in the tibial vessels while, in the phalangeal vessels while coming out.
So, you know, so you can see here, so this is, we went quite distal, really no other rotational device, or definitely no directional device could have gone this far. So we're going to get a balloon, we're going to have to balloon this. We'll do an IVUS and see how it looks. The patient is very, very comfortable. Give me the IVUS device, guys.
And we don't need any side flush through the sheath or anything whatsoever in these
No.
cases.
I mean, for sure, the one thing you didn't see here is there was a lot of plaque coming out the side port, which we'll show you in the other cut that we're going to have to do.
Right.
But you'll see here. Give me some nipride, guys. I want to inject some nipride into the foot as well.
So let's just see the. You don't want to spin the device when it's actually in the sheath.
You can take it out now. You can walk it out.
So,
You don't need
yeah.
to spin it. Yep.
50 per cc.
50 per cc. A little more. Okay, so we're out of the device. Patient is very comfortable. So now I'm going to go ahead and inject 200 of nipride. Actually, 150 flush, please.
Right, I put it right.
You flush it with saline.
Just flush it with saline from the sheath.
Okay.
Okay.
Keep flushing. Give me the IVUS.
You can take this device. Hold on, I'll give the IVUS.
So now, Vishal, we're going to go with the IVUS in. We're going to visualize. Off-road map, guys. Keep flushing, guys, till I tell you don't flush.
Okay.
I want to see a change in that blood pressure. He's just cleaning the device now. Okay, great. So the IVUS device is going in now.
You have the wire?
Yep. You saw there were two lesions in the foot. One is in the
Correct.
phalangeal artery, and
One
one was in the digital
More
on the dorsalis pedis. So obviously the phalangeal artery, we didn't go all the way out to the phalangeal artery. We just went into the distal dorsalis pedis. And you can see here, again, very smooth. There you go, very smooth.
Beautiful.
All right, Noel, play it now. Ready?
You can actually see the difference.
So you can see the difference here. Is it live, guys? Okay.
No, not yet.
Okay.
Yep.
There you go. See the size of that vessel there?
Yes.
All
That's
the
almost
plaque is
3
gone.
Yep.
Beautiful. No perforation. Very nice. You can put some color on, Noel, for me? It's just very poor flow. Okay.
Yeah, because
Yep.
there's a CT.
Probably
across the
occluding.
vessel.
Yes, exactly.
Again, very nice. Very nice. Very nice. So we're going to come back out. Now I'm going to go ahead. Now we actually created a nice lumen. Now I'm going to I'm going to give more nipride. Actually, no. I got my pressure effect that I want. Ready for DSA, guys? Fill the vessel for me.
Mm-hmm.
So you can see that this intravascular ultrasound is very useful at this stage, you know? And fill the vessel. Mm-hmm. Okay, ready? Inject. You know, I really don't even think we need a balloon angioplasty here.
Wow, looks much better.
You know? That's just spasm distally and where my wire is. I'm not too worried about that. I don't even think that I need a balloon angioplasty here. I think we're going to have to put a little bit more. I mean, to me, it was, if you show the pre-shot, guys, go minus for me. Look at that, it's just beautiful. No
It looks
dissection.
beautiful.
Minus. Minus before I had the wire in. Minus.
Right there.
Minus. There's one better than this, minus. Right here. So you can see the pre-shot here. You have the distal phalangeal lesion, which I don't think any catheter can really get down there. So you can see here how tight that was right there. You see that?
Yep.
And now you see how it is. So now the question is whether you want to do it proximal. So I think what we're going to do is we're going to change out to a larger device, which we've already done. So this device is the 2-2 device, and I want to do this first under guidance of roadmap. So let's shutter in, guys. Let's perform good, clinical radiation protection. Thank you. A little more. Oh, that's not radiation protection. There we go. A little more. A little more. A little more. Even more. Even more. Even more. There you go. Okay. Now let's do a roadmap.
The best radiation protection is put Farhan in front of you.
I agree. So we used to have a clinical from Volcano at one time, and she said IVUS would really prevent that. But now she's moved on to New Hampshire and Vermont and different areas, left New York. But I think intravascular ultrasound really prevents in terms of if you can mark your lesions properly by glow tape, do intravascular ultrasound, and then go ahead and use the glow tape to identify the lesion. You can pretty much do atherectomy, angioplasty, stenting without really doing fluoroscopy. So it really depends on if you have a good command of intravascular ultrasound, as well as if you have a good command of your staff that they put on glow tape.
So
usually
now you're
Dr.
using
Guja and I get here early to put on our glow tape.
Now you're using a 2-2.
Yes, we are. So you see here, this is a bigger vessel. I think Noel measured this at 3.5, right? So I think this is a larger vessel. And so we're going to go down here with this, and again, you're going to see the front cutting ability, the cut, capture, clear, which I think you're going to see. And we're going to try to show you some of the, it's not moving, try to show you some of the ability of this device to clear plaque.
The wire is dry.
I guess the big point to remember is because it's the front end cutting catheter, that you have to size it appropriately, otherwise it won't spin and won't do its job well.
So again, this is the larger device. Dr. Guja is going to put the wire in, create a fist, and do it. And then we're going to go ahead and advance this very, very slowly. And then we'll decide at the end if we need to balloon. I think two things we learned from the definitive series, Vishal, definitive LE, that directional atherectomy at least works very well below the knee. And I think it may be very transferable to these patients with atherectomy, period. I think, generally speaking, a treatment algorithm for below knee, generally for most of us, involves atherectomy to debulk, and then involves a prolonged balloon inflation. The reason for atherectomy is, one, to debulk, and two, is also to try not to have a dissection. So as you saw with the EASE trial, the rates of dissection were very low. Turn it on, please. So again, 1 millimeter a second, right? I'm going to just allow it.
If you could zoom into that suction port to see how the fluid and the plaque comes out, that'll be great. Oh, there it is. Good.
That's all the fluid. You slowly start seeing the blood. Now you see the blood coming in.
Yeah.
So it's not going to be a bulk of plaque
Right. No, I understand.
that you see in directional atherectomy, or So I really think that this reminds me more of like scrambled eggs. You're actually just mashing everything up and sending it down.
It's always good to see what to expect, especially the blood.
I just wouldn't recommend eating it with ketchup.
PK is getting more creative and creative, Vishal.
I think he's hungry. That's
I'm
what it
actually
is.
hungry.
Since past couple of weeks, he's becoming more creative and creative.
Actually, Liz forgot my bagel this morning.
So it looks
Okay,
like,
let's walk it out. So you see now, because of IVUS, we were able to identify. We don't have to walk it out. We're just going to do the proximal lesion. See the idea? Like, you don't have to walk it out. You can just keep on doing all the lesions. and we'll take a picture and do an IVUS right afterwards. So off-road map here, guys. Can you show me? Oh, sorry.
Come on.
So Dr. Guja's attached it back on just in case, and he's going to pull it out under the ability. A little higher, a little higher, a little more. I think this is the other lesion here. A little more. A little
Right.
more.
The whole thing is a lesion.
I think that's good right there. Stop.
That's good.
So let's play the initial angiogram, and then we'll look at the IVUS. So initial angiogram. So this is the value of glow tape when you do this. So that's the lesion we just took care of, minus. And then minus, yep, this is the other one. Here we go. So this is the proximal area above that. See, that's an area that we have to take care of. So that's, let's look at carefully with the glow tape here.
10.
That's around
15,
10?
30.
30 to 10?
Yeah.
All right, so let's go back to 30. Just now we don't need any dye, so we're at 30, right? Agreed?
This tape. Yeah.
Okay, ready? Okay, on.
Ready?
Mm-hmm. Very slowly, you can see the calcium there. Very effective in calcium as well.
Varun, put your finger here. Put your finger on the blood. No, the blood. Take your finger on the blood. Good.
I think key is not to push it. Allow it to actually get into the calcium, Vishal.
So Vishal, I'll show you when the blood drops in. I'll ask Farhan to take a drop of blood, and you can see the plaque actually in the blood.
So do you recommend doing a dry run, passing through the lesion first, or it doesn't matter if you can or cannot do
you
it?
don't have to pass it through and through the lesion.
Okay.
You can start going through with this because it's
Proximal
almost
end.
like a, because it's a front cutter. I don't think it's recommended, right guys? No. It's not like it's compulsory to do it.
Okay, now off. Scene minus. So now we did up to 10. Let's see if there was anything in the middle between 10 and 30.
It's just mild to moderate diffuse disease.
Any
but-
thoughts, Vishal, in terms of your treatment algorithm for PAD for below knee lesions like this?
No, I think it's a great presentation of how to approach lesions, especially getting inline flow in patients like these.
I think we're okay there.
And I think you covered all the lesions essentially. So I guess we should be good. We'll take a picture and see if you need PTA or it did its job.
Where? There? That's between
That's
what?
pretty good. Yeah.
That's where? What number is that? I don't have my glasses on. I can't see anything.
That's good.
25.
That's
Maybe
fine.
25 to 30?
25.
All right, let's go 25 to 30. So you can see here, it's not like we're giving dye. It's not like we're radiating ourselves. I'm doing this for demonstration purposes here. We're going to pull back to 25 here, and then we're going to go from 25 to 30. Again, the key is not to advance the wire when you're pulling it out, because if you have that viper wire in that toe, it's potential for having bad things happen right there. Good. Okay, now we're going to start now and go. Again, just 1 millimeter a second. There's a little lesion there, allowing it to work through that, allowing it to just go through. I think the key is trying to do both. Normally we would do, you can do laser atherectomy. You can do, obviously, directional. A lot of people don't like to do directional down into the foot the way we do it. But I think this device is a very simple device. Off. And as you see, it works quite well.
That's what I'm going to say. It's a very simple, handy device, easily, obviously in the right hands doing it. So
Take it out now.
with great results initially, like the picture you showed us. Let's see how it looks now. But
So I don't know
expect
whether
it
you
to
need
show
to
good
spin it every
results.
time you take it out.
Yes.
Only if there's a lot of friction.
Only there's a lot of friction.
Yeah, because I'm not a big fan of spinning. There's no friction now. You can take it out, right?
As soon as it comes into the device.
Yeah. Now you're in a big SFA. You don't need to worry about it. So now we're going to take a little picture. Maybe I'll give a little more nipride and take a nice picture here and see how it looks. Give me nipride again. I'm going to give the rest of it. Is that okay?
No, it's 50 per cc.
Okay. I'm going to give another 150 cc's.
So how about in cases where there's extreme calcification and you really want to try to use a filter? Would you be able to use it on a bare wire and use a filter?
Definitely not. I don't think they recommend using a filter in this case, right? Because you have potential of really causing damage to that particular wire, because the wire is a big deal. And I think, flush it please. I think that's a reason for this. You have to be careful. I mean, as far as calcium is concerned, can you flush please, Saline? As far as calcium is concerned, I think calcium is a challenge for any device. And I think that, I know that there's a lot of enthusiasm about different devices in calcium, but I think at this stage, that is one of the most challenging subsets. And I think it's good to have tools in the toolbox. The advantage of this device is the low profile, the ability to cut calcium, and the fact that it's very trackable. One of the problems I have with this device is that the wire choices are limited, so therefore it's very difficult for us to choose the appropriate wire, especially in terms of support. So for instance, this nitric wire, as good as safe as it may be, is not as supportive as our, Viper wire. So maybe, I don't know if a rotor wire would help, guys. Is that something we could use on this? No, right? That's another problem, because rotor wire is quite safe distally, and it can also be used for support.
Vishal, if you really have to use a filter, and if you're really concerned, the wire we probably want to use is a Viper wire.
Right, you still an 0181 wire.
Yeah, you can put this filter over the Viper wire.
Guys, I tell you, listen, you had 0% embolization in 0.9. I don't think we have the experience right now to say that you could. I don't think we've done enough cases, so I would stick to the company and say that we can't use a filter wire here, because that's what's been studied. If we have more experience with our clinical experience, then we can talk. No, but you can't put a filter down. Ready? Okay. Inject. I just don't want to give people the wrong information, because we usually give information based on our number of cases that we do.
Wow.
I don't even think you need the balloon, man. Maybe distally right there. At 5, we might have to balloon a little bit, but that looks pretty damn good.
That's beautiful.
Show me below, guys. Now again, listen, if I need to do another pass and everybody says let's do another pass, I'll do it. In please, can you come in? Shut her in a little bit more. I think as we get more experience,
one second.
As we get more experience, I think we can start commenting on filters and other things like we do with other devices. Because with our volume here, we really can put everything to the test and really figure out what works and doesn't work,
3025.
So it's a lot better, right?
Yeah.
The lumen is it's definitely affected that lumen. And what I want to do here is just do a 2530. Let's go with a 2530. Let's do a gentle balloon angioplasty and then decide.
You want to change it to a SparkCore?
I think I'm okay for now, because we're safe, right? This is a safe wire distally. So I think that's a great question that Dr. Guja is asking. He's like, do you want to change this now, And I think what we'll do is, at the end, because of the spasm we've created, we'll go down into the tibial, into the DP. We're not planning on ballooning that at this stage. We have a very nice lumen. We've affected the atherectomy very well. We'll do a final IVUS after we balloon here, and then we'll tell you how this looks. Now the key just becomes a prolonged balloon inflation of the dorsalis pedis artery, of the anterior tibial artery, without doing inflation of the dorsalis pedis artery.
Yes, definitely plaque, modified your plaque in the vessel, and it looks
well,
better.
I think proximally it looks phenomenal. In
right.
the mid-distal segment, yeah, there is still a lesion. But I think, it's an eccentric lesion, and I think eccentric lesions are going to be difficult to treat with this device, or with a laser in this particular area. So I think that, here with that kind of eccentric lesion, you're really, have to say to yourself, listen, if I can modify the plaque enough so that I don't dissect, I think you got to win there. So I think let's see how this looks, and then we'll look at the IVUS and decide whether or not there's dissection or not.
So, Pika, let me ask you from a clinical perspective, would you, for deciding on what kind of atherectomy device would you use, would you tend to, as a recommendation, recommend doing an IVUS first, deciding on how the calcification look, and then pick an atherectomy? Would that help in clinical perspective?
I think that adds a lot of cost, and I think we got to be cost conscious. Right now we're doing a live case and we want to teach and we're doing all this stuff. I think in this, in my practice, in our practice here at Sinai, I think you and I would have gone forward with an atherectomy device of our choice based on the angiographic evidence. I think that's also has to say, because we've done a ton of IVUS and we know how these lesions are looking, so our IVUS use is less. Plus, I think that's the real limiting factor for us is the cost. And I think until we have data that shows that IVUS can effectively reduce restenosis. We have my single center data with 100 and something patients. I think we need to have largest pool sets of data showing that IVUS may help reduce restenosis by preventing injury to adventitia. IVUS may help reduce drug-coated balloon use by using drug-coated balloons where it's needed, or drug-coated stents or Supera where it's needed. So I think you need to figure out where this is with a little more evidence. I think what we are really at this stage is in the early game of intravascular imaging for peripheral arterial disease. And I think the key take-home point for me, to everybody watching, is that I really believe that you have to incorporate intravascular ultrasound into your practice. And if you're very good with OCT and you know how to use OCT in the peripheral and you feel you understand it, I think that's okay too. I think you just have to figure out where it fits in. But I think the more the imaging software comes in with Philips, the more you have perfusion software that's I know is getting validated and I know it will become available. When that stuff happens, that's going to be incredibly powerful for us as interventionalists to choose the right vessel by knowing whether or not, and whether we've adequately treated the lesion to get the blood flow to heal that wound. I think that's going to be the most powerful thing. All these devices are wonderful. I think obviously the Phoenix atherectomy works really well, as you've seen. But I think at the end of the day, if we don't get the blood to the wound, it's not going to heal no matter what vessel we open. So I think that's another important part of it. I feel like I've been talking a lot.
Not at all.
No, it's just a routine daily work.
Everybody's a comedian. So, Dr. Kunja, can you take over a little bit, please?
I was just waiting for PK to stop. So, when PK doesn't get his breakfast, that's what happens. He talks a lot.
That's the double espresso shot talking.
All right.
So I think we can come down here and.
Yeah, I think that's
So let's talk a little bit about the time of balloon angioplasty. I know I said I would stop talking, but let's talk a little bit here. So in terms of your practices, guys, how long do you leave tibial balloons up? Show me a little higher, guys.
I leave it for 5 minutes, PK.
Yeah, we try to, right? Thank you.
I leave it for. I know Vishal. Do you leave it for 5 minutes too? I know that.
Yeah. Well, try to keep the angioplasty as much as possible.
Unless there is no other case going on in the other room.
Yes.
Again. So right now we've obviously undersized this balloon. Noel said it was a 3.5. We went with a 3. Again, I don't want to dissect. My experience with Phoenix is limited. We believe in the product. It's working well here so far. I would like to have a nice luminal gain here. Even if I have a little residual, I may leave it. But we're going to let the IVUS decide that for us. So we'll leave it up for 5 minutes.
I think it's a great device in our atherectomy armamentum, especially the ease of use, the aspiration associated with the atherectomy part. So I'm sure it's going to play a big role in yours and our practice as well, and especially people's practice, and the ease of using it. And let's see, how it responds. Like you said, we have limited experience, but I'm sure we're going to grow and probably come up with some data on it and try to see how it goes.
Instant restenosis. This might be a good device to use in instant restenosis because you don't have to worry about distal embolization.
But currently off-label.
Yeah,
right?
it's currently
off-label.
Yeah. It's neither contraindicated nor indicated, but over time when we have more experience with the device, this device, theoretically might be a good device for instant restenosis because it basically captures and cleans up at the same time. So
I'm curious. I don't know. I know we don't have the Rotarex device here. I know that Andre Schmidt and those guys talk a lot about it. I'm curious how it differs from that device. I know it's much more petite, smaller, more effective in terms of trackability, but in terms of thrombus removal, plaque removal, I don't know how that really works. Rotarex, for those of you who don't know, is really a thrombectomy device. And some people are trying to use it in soft plaque, but it's not available here in America as we speak. Don't advance it yet.
One of our viewers just wanted to know, is it indicated in cases with ALI where you use it for primary aspiration thrombectomy or not yet?
It's not indicated, but I can see where it may create a channel through soft thrombus. It may, but and likely maybe not embolize. But it's hard. Again, we're not getting theoretical in terms of our definitions. In terms of our definition for indications for use. So I think at this stage it's not studied. So we have to be very, very careful.
Okay.
So as you can see, the wire did move, and that's worrisome. We'd hope you didn't create any. Now I'm just going to pull it back even more to get it out of that area. I really don't want it to dissect that distal area. Now I'm going to take my Trailblazer down and take a picture. So again, you have very effective catheters, and wires. You have the command wire, which would have worked really well, but again, you're limited to using that here in this particular device.
You want to use IVUS again? Post IVUS?
Yeah, actually, let me take a picture below, and we'll give IVUS. So what we're planning on doing is taking a picture of the foot, giving copious amounts of nipride and verapamil, and then we'll study the foot. I don't want to create any more spasm there. We've already done IVUS there. I'm not going to go back there for the IVUS.
You have to give it.
Go ahead. Oh, I'm so sorry. And then we're going to go ahead and do IVUS of everything else. Okay, so I'm just going to take this down to say the distal ankle joint or the proximal ankle joint, whatever you want to call it, right about there, tip of the wire. And then we'll go ahead and take a picture and see how it looks. Pull out the wire, please.
You want to go a little bit
That's
down?
good. That's okay. There. Okay. So now we're going to go ahead with verapamil first, right? What's the heart rate, guys?
Nice blood flow.
52. So no verapamil. So Liz is saying no verapamil. So what we're going to do is we're just going to use some nipride.
Give me a smarter code.
I think this is what people don't do enough, you know? Use tons of
50 per cc.
50
per cc.
Yeah, I'm going to give 4 cc's. Okay.
New York Heart and Vascular has made.
So it would be nice to give some verapamil here, but
New York Heart and Vascular,
you know, to
they have
reduce
a
the
background
spasm.
on
I think that's one of the underestimated things in doing below the knee intervention is using of vasodilators like we do. I would recommend I usually do use a lot of vasodilators after PTA, before
Really?
PTA, after atherectomy,
more so.
just to make sure there is no vasospasm and leading to other issues and you have poor blood flow and all this stuff. So
Yeah, I think you
it's very
really have
essential.
to. I really
Right.
do, you know. You know, the other problem is this wire moved a lot, as you saw from where it was, and I think, you know, that's another issue. You know, that was not the Phoenix device's fault. That was our exchanges and things we were doing.
Right.
You know, the Phoenix device, you know, holds the wire in place. So, flush. So it's not going to, you know, cause that. So, you know, and when these wires move around more, please. When these wires flushes. Yeah, I like the little CC. So when these wires move around, you know, they create a lot of spasm. And it still have an effect of the blood pressure. Can I have more nipride, please? So you want to look for a systemic effect of the nipride. You know, if you don't have, you know, if you don't have a systemic effect, you're really not getting nipride into that distal vasculature. So you really want to try to use more and more nipride and flush it deep within. And this is the patience, Vishal. I think you have to exhibit a lot of patience in below the knee. Fill the whole syringe, please. You want to exhibit a lot of patience below the knee. You know, okay, a little more drop in blood pressure, but I like it to be around 40 or 30 diastolic, not systolic. So there we go. Another 3 cc's. Dump that up, please. I think sometimes it's also the force of how fast you can inject nipride.
Well, you have to give it time to come back. The arm to heart circulation is 13 seconds.
have the break,
Yeah.
so he's injecting slowly.
He's just injecting everything.
Injecting slowly.
Let it come back to the
All
heart.
right, let's see. I think now he's feeling a little bit of burn in the leg, which is a good sign. Give me some dye now, guys. Okay, dye? Okay. Okay, we're going to do a little DSA picture.
You're not DSA.
Okay.
You might want to. Might be a lot of flush.
And that was caused by the wire.
Yep.
So that's the wire spasm. So give me the field of wire here, guys, or a command. You know what I mean? I don't know. So we're going to go back in. No roadmap. Nope. No roadmap. So this is what happens when the wire pops up. Back up now. When the wire pops up, what happens is that you go back and forth in an area that's been disrupted. No, move your off-road map. ¿Qué pasa? So, no problema. So when the wire pops up, what happens is that you go ahead and irritate the vessel, and you create this kind of look. So you just want to go down a little more distal. Okay, roadmap now, guys. Mag up again one more.
The atherectomy side still looks great, so I think
Yeah,
that's
it looks great, but the problem is you have distal spasm.
Right.
Roadmap. Okay. See, the atherectomy side looks phenomenal, but there's the horrible spasm. So now I'm going to go in with a command wire.
I gave you a field.
I know. No, it's a command. Give me the. Give me the thing. And, oh, you made it, Tip.
Yeah,
Thank you.
I made it.
So we have a tip made. Yeah, let's see.
Yeah, there were some diffuse disease down there, so
Well,
probably it just
remember, I
got
was
worsened.
worried, and that's part of it. Even with our precautions, we shut it down, but that's okay. We'll get through it.
Oh, move one.
My fault. Sorry.
I don't know who hasn't had breakfast today. So we're now going in.
Hey, Damien. I got 158. 158.
That looks better.
No te mueva. ¿Duele? No, no duele. Okay, no problem. Off-road map? That's definitely a loop, right?
Right.
See? So that's good. So now we're going to take this distally. Now we're just going to give a little dye. More nitride, guys? So you see how nicely the command wire was able to track? So now we're going to go ahead and give some nitride in. This is nitride? Yes. Okay, blood pressure is still a little low. Give me a plain syringe, guys. 3 cc. 3 cc, just empty that out. Good. Let me take a look. I mean, I definitely want to balloon this. So I got copious blood return here. So I'm just going to inject lots of nitride in. This is saline. Give me the dye, please. Dye.
So Vishal, one of the problems with the nitrix wire we have, right? So I've observed that after we do atherectomy, you might want to switch off your nitrix device, because nitrix wire, because see, your nitrix wire is a very flimsy wire.
Very nice.
So if you start using your balloon over the nitrix wire, you might not be able to control it once you
So
especially
give me
inflate
the
a long
command
balloon.
back now. So you see how that created that little haziness,
Right.
which is all from the movement of the wire. And this is the major problem we have with angioplasty. With atherectomy, anything, is that when we take these bulky devices over, the device itself caused no problem here. It was the balloon. Once we started getting sloppy with the balloon, this is what happened. So, the key here is, you have to recognize it, you have to do pre and post shots, and now you have to balloon it. So that's what we're going to do here. I'm just gonna get this in.
Into the loop.
I'm going to do a little bit of wire Fogarty, as we call it, and then decide what we want to do. So again, having a smooth, silky wire like the command is going to help us here. I'm going to try to see what I can pop it into this vessel right there. There we go.
It's a loop, right?
Yeah.
Plantar loop.
There it is. See that?
Put it in.
So now I'm just going to take this in. I tell you.
Yeah, sometimes it's hard to get that trailblazer
Yeah,
down.
it's not going in there, is it?
Yeah.
Yeah. I think here a
There.
coronary device may be helpful too.
It's an 018.
Yeah. Well, let's leave it here for now.
You can put the balloon down.
Yeah,
Well,
you can exchange
this
it
is
for
not
a
really
small
the vessel
balloon.
I'm concerned with right now anyway.
Right.
Let's not, I'm going to leave the command there safely in a loop here. And now I'm going to do with a, let's get a road map here, guys. Ready? I might even send the Phoenix down again. That right there, inject. Again, it's all saline on and off, guys. Inject.
A lot of saline.
A lot of saline. Okay,
Yeah.
on and off. Fill the whole thing. Okay. All right. Now show me scene minus now.
PK, for time's sake, do you want to show the do an angiograph and show proximal images first and then come back and work on the distal edge?
No, I think we have to do this here, Vishal. Go to the first scene for me, guys.
Oh, that one?
Uh-huh. Go to the pre-shot for us. Go to the diagnostic shot. What is it? What vessel is this?
1580.
1580. You have a short or 1.5 balloon? You have an Avid balloon, 1.5 short. No. Minus. So I'm trying to look at the state of that plantar loop before we started.
Right.
Right? Minus. See, that was right there. You see that, Vishal?
Yep.
So the loop was open.
Where it is.
Yeah, so give me a 1.5 short balloon.
20 or 40?
20 is fine. 20 is fine. So let's see this trackability of this balloon in there.
Yeah, there's some disease even in the plantar loop, but again, you're right, it's a very small vessel, so
It's very small.
any trauma to it can just worsen the outflow, so that's what it is.
There's no question. There's the wire snuck in there. There's no question. As you can see right there. You see that?
Yep.
There's absolutely no question.
Don't have the one. Yeah, I have it.
Okay, don't move the device,
Yeah,
please. So if this does not track, there's a very trackable balloon. If this doesn't track, then what we may do is just go with a coronary style balloon here and do it. It's not. I don't think this will track into that loop. Let me just do it. Hold on. So we're trying to get the balloon down there.
Right.
Okay, guys, let's balloon here first.
What's the wire?
No, wire's good. So we're going to leave a prolonged balloon here. Go up.
I'll probably go down, daughter it, and then.
Yeah, I'm just going to start proximally to distally. What's nominal with this balloon? 8. So there's the balloon at 8. We're going to leave it up for 5 minutes. So I think it's important that this illustrates the importance of knowing your pre-anatomy versus your post-anatomy. So you can see here that the wire dissection was caused, and that the wire dissection obviously shut this vessel down. So now what we're going to do is we're going to do this. Now what are the other options? So what's the modes of failure here? The mode of failure is going to be, well, if the vessel recoils. So one of the things that we could do is run the atherectomy catheter back in, go ahead, cut out whatever plaque that's hanging in the vessel, and then go ahead and do another prolonged balloon. That would be my second step after this particular prolonged balloon. As far as the plantar loop, what I'm going to do now is I'm going to get a coronary catheter called a fine cross. I'm going to go into that and give copious amounts of nipride and open that up. That'll be our next step. So let's get a Viance, guys. I need much more nipride. Okay, so let's go scene minus for me here. The other thing is, why did I do proximal versus distal? So the proximal vessel is bigger here. So therefore, if I do a balloon angioplasty of the proximal vessel, and if it occludes there, likely the flap starts there. If I can tack up the proximal flap with a prolonged balloon, there's no reason for me to go distal. The vessel keeps getting smaller and smaller. So a lot of times, you know, a lot of young operators will go ahead and go distal or go with a longer balloon. I think here, the exact area where the vessel closes is the beginning of the flap. If you remember when we took a picture of the wire after we took the balloon out, you saw that the wire was stuck up in that proximal segment, and I was immediately concerned. So I can tell you that that is the main reason why this happened, and what we need to now is, now you're going to learn how to fix it. So what about stenting here, Karthik? Would you ever stent this segment? I'll leave it up.
No.
No. What about you, Vishal?
No.
Well, I mean, listen, you can never say never, but there's not a good reason or a good area to stent. You know, one of the things that you want to do here is try to just stack this up with a balloon as much as you can. And you know, I will go with longer balloons. This is an area where the stent will get crushed, probably not as quickly as it would right over the ankle joint, but you know, this is just not a good area to stent. You know, so hopefully we can get away with this with the balloon angioplasty. Let's come down here.
So I guess you're absolutely right. It's just identifying the cause of the issue is what really would help us drive. If it was a thrombus, obviously I'm sure you'll do an aspiration. If you think it's dissection or injury, you probably do it with the PTA.
DSA.
So I think the biggest thing is to first identify what's causing it, and then of course take appropriate steps on it.
So we're just going to give I still have the balloon down there, but I'm just going to give a little dye just to see how it looks. You can see the back and forth, right?
Yes.
That means we're still not to that spot where we need to be. So now I'm going to go back to the other vessel. Give me the C minus. I'm going to go to where we injected. Okay, if that's the spot I want to see, right here. You see this? Okay, now freeze that for me. So now I'm going to use my bony landmarks, and I'm going to go to the tip of that curve of that vessel. Ready? That's it. Freeze that, put it on this side. You see how that vessel is all sheared? So all the wire jerking back and forth when we were doing. Give me off-road map, guys. I mean off DSA. Okay, good. So you see where that wire makes the turn?
Mm-hmm.
That's where I need to go to.
Right. I think that'll be the most technically difficult part.
That's the maximum I can go distal. Right there. Let's go up again. And then now I may go with a longer balloon. Give me the 40 balloon, guys, 1540. So this is one of those that when this happens to you, you want to send it to your favorite competitor. Say, hey, listen, you know, you're the only one who can take care of this. But you can see in the prior shot, can you focus on the still film on our saved image? I want to talk a little bit about the angiogram, the second monitor. So if you focus on the second monitor, you can see the area where the wire tore the vessel. You can see that the tip of that nitrix wire probably went in right at that area. Do you see it? Do you zoom in? Can you show, Karthik, with a pointer? You can see the plaque, and I think we need to go with a bigger balloon here. Guys, get me a 2040 here. A 2040, even a 2060 balloon. Actually, 40 is good, guys. 2040.
So this is probably where it tore, right here.
No. Right. No, higher. Right there. No, higher, even higher. Yep. Right there. That's where the vessel occludes. So when you see where the vessel occludes, that's the area of the injury. Down. Let's walk this out because I think I'm undersized with this balloon. Down. Huh? It's. I think we're gonna have to go with a bigger balloon here. So we're gonna walk this out here. Huh? 2-0, yeah. Let's walk this out. Yeah, walk this out. Watch that wire distally. No, it's okay. That's good right there. You're good right there. That's okay. Even right there is okay. So now we're going to walk this out. Let's do a DSA quickly. Inject.
Yeah, right. We need a probably longer balloon to just.
Yeah, we need to go with a bigger balloon. A longer balloon, I agree. Give me a 2040. You can see the arch is opening up through the other vessels, but you really need to get this. Okay. Off, put me on coronary, guys. Anything you would do different here, Vishal?
No, I think that's the right. I mean, you're right. You just probably have to use a bigger size balloon, close the flap up, give a lot of vasodilators, and hopefully that'll open up. The biggest challenge, like I said, is just taking that turn and trying to inflate it. So let's see. Hopefully a 2 balloon, I think, will be the right approach to do it.
Not going forward. There I go. Give me a dry gauze, guys. There it is. Where's the distal marker of the balloon?
It's, that's the distal marker.
No, I see the proximal marker.
No, that is the distal. Right there.
Okay, let's go up here. Right here. Okay, I'm going to pull it back a little more proximally because it's a bigger balloon. And let's do a nice 5-minute timer here, guys. Go. Did you put dye in this or no? I don't think they put dye. Oh, coming out here. That's why. Go up. Slow. Noel, what did this vessel measure with IVUS?
You can even see that calcification lining going all the way across into the loop, even on a dry fluoro.
Give me a little dye to inject through here, guys. 3 cc. Hold this. Give me a new one. Give me a new one of those.
3.1.
Huh?
3.1.
3.1. Okay.
Yeah, I would still go with a first starting with the 2.0 and then go up.
So now we're all watching paint dry. Can't inject. So what, I mean, in terms of algorithmically, is there anything else you guys would do here different?
No, I guess from my perspective, it'll be the same thing, just trying to establish flow by increasing the balloon size. It'll be hard to take the turn, like you said, going across into the pedal loop. That'll be difficult to do. And hopefully with the sequential increasing size and doing PTAs with a lot of vasodilators, it should open up. You're still getting blood flow through the collaterals and the other phalangeal branches. So,
well, you definitely increase.
I think it will heal with time. If worst case scenario, if you're not able to establish full line blood flow, but
yeah,
but I guess that'll be the last resort, which we would not like angiographically, which I agree with you, and we need to work everything to get that flow back up.
So you almost have a calcium roadmap here.
Right, that's what I'm saying. You can clearly see the calcium taking that bend. So it is definitely calcified.
I think we need to go with a bigger balloon. Give me a 2.5 ready, guys. There it is. Good. Now I want to get the other vessel. Huh?
It's a very acute angle. So
Yeah, I see it.
Do you think we were the part of that 1%, whatever, 0.5% that it distal embolized?
Yeah, I don't think it's embolized. I don't think this is embolization if you see the haze. This
Right.
doesn't look like embolization to me. How many minutes are we up?
We are at 3 minutes and 10 seconds.
All right.
Why did you come down? 5 minutes.
Almost there.
Okay, down.
You want to make
Let's just get a better balloon. A better balloon. Down?
a bigger bend and then do it?
No, it's okay. I'm good here. I'm good here. We're going to walk this back. Let's set up on DSA, guys. Leave the wire where it is. Sorry. So far, we're an hour and 20 minutes in. Not terrible. Ready for injection? All right, get the Phoenix ready. If it's not working, I'm running it again. Yep, ready? Inject. You give me the Phoenix device now? Give me the Phoenix device for sure. So we're going to go in now. Oh, I got to change this wire. So give me the what's it called device? Yeah, and give me the Viper wire now. Give me the fine cross. So what we're going to do now, Vishal, we're going to change this out. We're going to go with a more supportive wire and try to get the Phoenix distal. Can I have the fine cross, please? Great, thank you. So what we're going to do is we're going to take the fine cross distal. We're going to switch out for the Viper wire, and then we're going to run the Phoenix. I want a Viper wire with a nice curve in it, please. A big curve, like a C curve, a U curve.
So you're taking a fine cross?
I'm going to take the fine cross distal into that branch. Ready? You got it? Put me on corner. So what I'm going to do is take the Viper wire to that calcific area right there, that bifurcation, and I want to try to wire into that lead vessel into the proximal phalangeal artery. Okay, let me just give a little dye here to understand what the hell's going on here. Okay, give me a little dye now. So now, if this fills now, then you know this is a dissection flap. That's all it is.
Right.
If this fills, it's a dissection flap, huh? I want a Viper. Yep, absolutely. So everybody go to DSA again, guys. You got it? Mm-hmm. So if this fills now, it's completely a dissection flap. You see that? You see what you're dealing with?
Right. So it's technically more distally because
No, it's not distal. It's proximal dissection flap. So remember, when the dissection flap closes, now what I want to do is now I want to be able to get I want to go back with the command, get into that little branch, right?
Why do you need it?
And what I need a command. I need a command. Oh, you know what I would need.
Yeah, I know.
Yeah.
I know.
Give me that.
Yeah, I have it.
Give me the wire. Yeah, that's it. This is what I want. Yeah, it's okay.
You go with a bigger size balloon.
Now look, I'm going to show you. So what you want to start to understand is what's happening here, right? See, that loop will open up because it's collateralized through that proximal branch. I'm okay with that. What I would like to do is get this into that other branch, which is that proximal phalangeal branch of the great toe. I also want to go into the loop. Now, this is not a fine cross, guys. Yeah, but I asked for a fine cross. Yeah, but I wanted to go with the fine cross first to see where we were, right? All right, give me another wire here. Give me the fine cross again. So what I'm asking for is to go into the arch now,
Right.
and inject in that arch. We know that the Trailblazer is not going to track there. Or the other thing we could do is say the enemy of good is better and just open this one area and leave it. Which, since we have collateralization to that other area from the proximal branch of the DP or the tarsal branch. You know what I'm saying?
No, I get it. That's what I was.
So that's also another argument where you could say, hey, listen, just leave it with this. So just leave it here and then go with the, yeah, it doesn't seem to want to go to the other branch, so let's just leave it. Let's follow it. All right, so then give me the, all right, now give me the Viper wire. Let's do what Karthik is saying to do. Makes sense. And then let's get the Phoenix device. You know what I'm saying? No? Why? Give me the looper. Why? Karthik is saying he doesn't want to atherectomize. Tell me what you're going to do. Why?
Me neither.
Yeah, I think so. I don't know if this is a wire D, but I think it's we did the atherectomy, we didn't balloon it, and the wire came back, right? So if the atherectomy device might have created some dissection plane. This could be a flap from the atherectomy device. We didn't tack up the atherectomy dissection plane before the wire came back. That was the reason why I said you always want to switch out to a stronger wire before you put the balloon back in, because that's a Mitrex wire is a very flimsy wire. It doesn't stay in the vessel, no matter what, especially if you start losing longer balloons, right? So when the wire came back, probably the atherectomy flap probably just tacked in. All you have to use is take bigger balloon that area where the phalangeal stenosis is, and then just give outflow. That's what you have to do. Do you agree with Vishal?
That would be my plan too, just
Yeah.
to do a PTA, prolonged inflation, and see how it is.
Yeah.
And like I said, worst case, if we're not able to
So
establish
if that's the case, why did it not respond with PTA that you just did?
Because it's probably a bigger vessel.
It's a
probably
bigger-
bigger
yes,
flap. You might want to
exactly.
use like a 2.5 balloon and just leave it there.
But-
and also the distal stenosis in the phalangeal arteries
Is causing
probably is
the
not
issue.
giving you outflow.
But it was giving you outflow with the stenosis. Why would it give you an outflow now? No, I don't agree. Let's see the Rotarex.
The Phoenix
Rotarex.
device.
Phoenix. Call it a Rotarex. Give me the Phoenix. Actually, Noel, let's do an IVUS. Give me the. Oh, IVUS won't go on this, right?
No.
It won't go on it.
Will it go on this?
Yeah, on the
Okay,
Viper wire.
let's give me the IVUS. Let's do IVUS on the Viper wire.
We're still okay with the time, PK. You gave a long presentation.
No, it's okay. Time's okay. But I think that's
Yeah, I'll
important
give
for everybody to understand. Let's see. No, we're going in. No te muevas, señor. So again, you can see the utility of IVUS here. The IVUS is going to let us know exactly what's going on in this vessel, take all the guesswork out. The problem is the wire may be propping the vessel, the dissection flap open. So that's another thing that you need to realize. All right, let's start. You got it? All right, ready, play?
You actually have flow now. You see color flow now.
Well, you can see the flow going down there, and the
Yeah.
vessel side is
Yeah.
definitely.
You see color flow now in that vessel. So.
It is like a 2-0 vessel right there. Here it starts to increase in size. I think we're more proximally than we were at the lesion, but
But I don't see any obvious dissection flap. So this could all just be recoil. Show me when that branch shows up, Noel.
Right there.
So you can see there's no this thing. So now let's take a DSA shot. Ready, guys? So there is recoil, because when I pull this out, it flops closed. So give me a short coronary
Clear.
balloon. This is what, an 018 wires or 014 wires, IVUS? It's an 014? All right, give me the Phoenix device now.
Don't take it, PK.
Okay.
Trust me. I'm telling you, this
Tell
device
them.
is.
Scene minus here, please. So if you believe, so if you didn't see a dissection flap,
So let's-
and
let's-
it's
this is what-
closing.
This is what device is this?
This is the
not-
smaller one.
Small
What's-
one? You switched out?
What's
Did you
going to
connect it?
happen is that there's recoil occurring. So actually now atherectomy is indicated for this recoil. So what we're going to do is we're going to go ahead and atherectomize slowly. We didn't see any obvious dissection plane. So if this is recoil, now the other counter argument is that the dissection plane may be, huh?
Okay. So
Huh?
flush it again?
So this is the picture after the
Let me see
IVUS,
that.
but no PTA.
Let me see the thrombus. No, this is the picture after IVUS without PTA. Yeah. Yeah, but that's the disrupted area where you probably have a dissection and a thrombus. No question. But I don't think IVUS is good at seeing thrombus anyway. So I think over here what you want to do is you want to run this through and then do a balloon angioplasty. We'll see.
What size balloon do you want? I have a 254. Do you want?
I want a coronary 1.5 first.
1.5.
You can put it into that balloon right at the lesion level
Uh-huh.
and balloon into that branch.
That's what I'm going to do, yeah.
Yeah,
But first I'm going to run the prop.
That is very, very,
Hmm?
it's very tight. You have it? Yeah, good.
Oh. Okay. So Farhan, you see that distal wire? Don't move that dot.
Don't move
Ready?
that dot. You heard it? Don't move that dot. That dot moves. You chop your hands off.
There you go.
Every centimeter the dot moves, your fellowship gets extended by a month.
Yeah, so the dot moves, we're going to chop
Lift it up, please.
Farhan's
Yep,
hands
lift
off.
it up. Yep. Yep. A little more. So here we go.
Oh,
See? Moved. Watch it. PK, let me pull it back. It's a wipe.
It's okay. Nothing going to happen. That's good right there.
Let me pull it back. It's a wipe.
I'm okay. I can see the dot in the field. That's all I care.
1 second. 1 second. Okay, 1 second.
Okay, good. Scene minus here, guys. Don't pull it back blindly, please.
I'm just keeping backward tension on it. Because it's very.
You can put it on. Show me the distal wire, Farhan. See where it is. That's okay. Okay.
You can't. It's really tight. So wipe it a while.
You go to coronary here. Why? You said it's the size of a fist. Right? Ready. Perfect.
My fist.
Okay, ready?
One
Now
second, one
C
second.
minus here, guys. So I'm looking at the bony landmarks underneath to see where I should start. So you can see here, looks like the base of the talus. So this is actually a good spot, maybe a little
Ready?
lower. A little lower. Okay, start now. Why is the wire coming back, guys, like that?
It's stuck to the device. There's nothing I can do.
Okay, off. Off. Walk it out now. Again, you want to rotate it and walk it out?
No, flow.
Oh, you want to have more loop there?
Yeah.
So you see how Dr. Guj is walking this back by increasing the loop? I think that's very interesting. He allows him to pull back a lot further and then again extend the loop to be able to walk it out so the wire doesn't move and doesn't rotate in the vessel. Let's take a picture, guys, in a second. Actually, give me the 1.5 balloon. Let's balloon the outflow first. Uh-huh.
Fell down.
Get us another IVUS. This IVUS fell down.
One sec. Nothing I can do. It's just stuck. Shit, the wire kinked. Yeah, wire kinked also.
All right. What's happened?
Wire
frozen?
kinked. Wire is bent.
Wire is bent.
Yeah, it's a Viper wire. That's why.
Okay, the wire is bent. Okay, no problem. All right, let's take a DSA shot here. No issues at all.
It's a Viper wire.
Inject.
Take the fine cross.
And then there was light. So I guess the old man knows what he's talking about. Not bad, huh? Not bad. It's time to gloat.
It's time to gloat.
Forget the balloon angioplasty. We're done, boys. We need atherectomy. Ready? Let's go. So Vishal, I would like a nice glass of wine later. Karthik,
Vishal, I think we can still stick to our plan.
champagne from you. You guys have been ballooning, hanging out all day.
I think, Vishal, we can still stick to our decision. I
so
think
to
that
the
what
audience
we
at
said was
home.
right.
So to the audience
Because
at
the
home.
flow was there before the atherectomy device.
Unfortunately, we could show 5 different areas where it wasn't. But to the audience at home, I want you guys to find the most senior guy in your practice and shake his hand. Ready? Inject.
I still beg to differ on the etiology,
Okay,
but we'll talk
okay.
about it later.
Sounds good. We'll argue later. So you can see now we have reasonable flow down. Yep, very good. I think we're done, boys. So
Beautiful.
maybe distally we'll do a little touch-up balloon there, but I think we're done here. Very nice. We're going to give some more nipride. Nipride, please.
Vishal, nipride is back ordered in the United States
Inject.
because of because of sign I use.
That's true. We use a lot. So you can see here, I just want to go over what the thought process was. Excellent. All right, we got great flow down. All right, we just may touch that up with a larger balloon. Okay, so let's give plenty of nipride and wait. So let me just go over the little idea here on what happened. So what I believe happened, which I was right, is that the wire actually dissected the vessel when they pulled out. So when the wire dissects the vessel, in terms of when you're going with larger balloons, and I think Dr. Guja's idea of switching the nitrix wire out for a larger wire, or for a safer wire such as a Spartacore, or for a more workhorse-oriented wire would have helped. Nitrix is very slippery, obviously moves back and forth, and as I said earlier, that's one of the limitations of this device in terms of the fact that you only have 2 wires that I know of that you can use. So clearly, if you're strong enough in terms of your ability to use the Viper wire safely, that's obviously what we did the second time. So maybe in retrospect, we should have gone with the Viper from the beginning. But having said that, if you lose a vessel, okay, in the foot, 2 reasons for vessel, actually 3 reasons for vessel loss. 1, recoil. 2, dissection. 3, thrombus. Same thing. So what the first thing you need to do is get distal to the vessel. Once you get distal to the vessel, you need to make sure that you still have distal outflow. Once you have distal outflow, what you want to do is, with the catheter in, inject through that catheter, as you saw multiple times we did. When you inject through the catheter and the entire dissected vessel or vessel that was not seen is now retrograde filled, what does that mean? Well, it's not thrombus, so it's either dissection or recoil. Intravascular ultrasound is your solution. You put the intravascular ultrasound in, and then you go in. You make sure that you don't listen to them when they tell you there's thrombus. But the truth of the matter is that you can see in the intravascular ultrasound very clearly whether there's a flap or not. Here, there was a questionable haze in the vessel that was seen both angiographically and with intravascular ultrasound. The haze in the vessel told me, personally, that this was a dissection flap. The dissection flap was being held up by the Viper wire, which is a very strong wire. So therefore, what you need to do is go back in this case, and you have only two choices. One, prolonged balloon angioplasty with a larger balloon for 5, 10, 15 minutes, okay? Two, if that fails, go ahead and stent. Three, off-label use of atherectomy to cut out the dissection flap and any residual thrombus. And I think here the Phoenix atherectomy catheter worked very, very well. So now the guy has excellent outflow back to his feet. We're going to go ahead and do a further balloon angioplasty, of the distal AT where it was a little lower by doing IVUS guidance, making sure that we have a good one-to-one result of that vessel, and then we're going to end the case. So again, I thank all of you. I thank obviously the Phoenix Atherectomy, Philips Volcano team for being here. They've been incredibly helpful in this device. Thank you, gentlemen and ladies. And I'd like to thank our wonderful nurse Elizabeth and Farhan Majid, who didn't say much today, but we thank him, and as well as our intervention fellow Suraj. Lastly, I want to gloat. So now you see that experience does pay. So Karthik and Vishal, I'll have my wine today after hours. Thank you. I'll see you guys next week. I'll see you guys next month. Thank you again.
Thank you, PK. That was a great case explaining the newer technology and specifically when you run into trouble or relative trouble and how to get out of it. The thinking process, the various availabilities of technology and how to proceed. Thank you everyone for joining us for this long case, and thank you for staying long enough. For people who had to log out for other reasons, you can go to our archive section by the end of the week and view in this remaining part of the case of whatever was left. We'll be here again next month, December 21st, for another interesting live case. Any questions, you can email us at info@peripheраlinterventions.org. Go to our website, peripheраlinterventions.org. We'll be more than happy to take any comments or suggestions. Thank you, and have a happy Thanksgiving early, and we'll see you next month.